once again, thank you everyone for joining us this evening. My name is Daniel Winter, and I'm the OTAC Coordinator, as some of you may be aware of. With the OTAC, we run a series of training courses and educational activities, and as many of you are aware, as you have registered for this, we do run sort of monthly case-based webinar. And this evening's topic is on sedating substances and opioid agonist treatment. And we have along with us today Dr. Rowena Penafiel and Dr. Sharon Reid joining us as well. And I'll get Sharon and Rowena to introduce themselves in one quick second. But before we do go any further, as always, I would like to make an acknowledgement of country. And I would like to acknowledge and recognise the traditional owners on the lands of which we all meet this evening. This evening I am based on the Gadigal lands of the Eora Nation at RPA Hospital, where I also work. And I would like to pay respects to those elders past, present and emerging, and extend that recognition to the lands on which we are all meeting this evening. Otherwise, I think I might just briefly hand over to Rowena and Sharon to introduce themselves and we can get started.
Rowena, you want to introduce yourself?
Hi, I'm Rowena. I'm an advanced trainee in clinical pharmacology and addiction at Drug Health Services Sydney Local Health District. So I worked 2 years as a junior doctor, then 3 years of basic physician training. And after the physician exams, I started advanced training at RPA a year ago.
Great, thank you very much, Rowena. And for those of you who haven't met me before, I'm Sharon Reid. I'm a GP by training, working clinically in drug health services at RPA. And I also have my fingers in a couple of different pies in different academic and research activities and you name it, typical GP. Anyway, so we progress. I just want to quickly outline the aim and format of these case-based webinars for people that haven't been before. But essentially, we're trying to provide a comfortable, beneficial environment for you all, OAT prescribers and interested others. It's online via Zoom, and afterwards, Daniel will provide relevant resources available also on the OTAC website. We aim to try and stick very close to time so we can all not be up too late. And as I said before, Daniel will send along learning resources and certificate of participation after the webinar. Is there anything else to say there? No, I don't think so. But the only thing I do want to say is if you have any interesting cases or ideas or an interesting patient or scenario you think might be valuable to discuss at these type of sessions, and please let us know, because we're always looking for new information and relevant cases. So just housekeeping again for people that haven't been before. So keep on mute, but when you do want to speak, either raise your hands or put a comment in the comments part. And if you do speak, ideally put your video on. We have this is largely based around case discussions, so it might be helpful for you to have a pen and paper or a notepad just to jot down some things for questions for you to ask and things about cases you want to remember. And as I said before, raise your hand if you want to ask a question and introduce yourself when you do. A reminder, this webinar will be recorded for people to listen to afterwards, so please don't reveal any identifying information about cases or any other confidential information. And of course, always be considerate and polite to your colleagues. And please let us know if you think there may be any relevant conflicts of interest prohibiting your attendance at these webinars. Now, I think the format here basically is that we allow about 10 to 15 minutes per case. This week, we've got a slightly longer case at the beginning and shorter cases at the end, so we'll see how it goes. And as I said before, be prepared to think quickly. We ask you questions before and after each scenario, so you can, suggest your answer and then have a think about it after you've learned a little bit more about it. And as you're thinking, think about the case details that are important, what you'd like to know, and what you would say to your patient. Now, this webinar is entitled Sedating Substances and OAT. And as I said before, there are 3 cases, 1 longer and 2 shorter, and the online polls before and after. Now I'm going to pass it over to Rowena.
Thanks, Sharon. So the first case that I present today is a 33-year-old male who was released from jail a month ago, and he's currently on 130 milligram methadone, and he has had 3 pregabalin and clonazepam overdoses in the last week, and 2 out of 3 presentations he has discharged against medical advice. These overdoses were in the context of long-standing pregabalin and benzodiazepine misuse. Next slide. So the question here is, would you continue to prescribe methadone for this patient?
So if everybody could just think about this scenario and look at this poll and just your first thoughts, you can revise later. What are your thoughts about continuing to prescribe methadone on this patient? Would you prescribe, yes or no? Please answer the poll as quickly as you can, and then we can move on.
And we've got about 65% participated, 70 streaming up nice and quickly. Have a think as well if you've got any points that you want to discuss, or what more would you like to think about, with this case as well. But I think in the interest of time, I might end the poll and let's see what everyone else has said so far. Oops, sorry, share. So most have said yes in this case, Sharon.
And so 72% said yes and 28% said no. Great. Okay, thanks very much. Do you want to keep going, Rowena? We'll just sort of
okay. Yes.
keep those results in mind. Next slide, did you say?
Yes.
Sorry, I missed that. Is it moving? Sorry.
So the discussion points include the question of whether you would continue methadone with this patient. What are the risks with ongoing methadone for this patient? How would you initially approach this patient about your concerns? And what alternative treatment options would you discuss with this patient?
Now, Rowena, I can give you a little bit of feedback about what's happening in the chat.
Okay.
So let me just have a look here.
So someone had written about prescribing at 40 milligram per day?
Yeah. Yes. Dan suggested prescribing about 30 to 40 milligrams per day, not 130. So Dan's suggesting to reduce the dose quite significantly. What does everybody think about that? Maybe you could try the thumbs up or not sure. Is there a sort of a in between? So Wendy suggests agreed with Dan. Brian Sekol wants a little bit more information about the context of the overdose, whether it's intentional, self-intentional or accidental. Do you want to give any more information about that, Rowena?
So it was recreational. The client had a long-standing history of polysedative misuse. The client was also vulnerable given that they were a recent release from Justice Health. And in terms of the treatment, especially with one of the overdoses, they were requiring more than 1 bolus of IM naloxone. So at the time we did a brief intervention with the patient, we did tell the patient that he nearly died of an overdose. And we did express our concerns that he was presenting for dosing intoxicated and quite sedated, given the combination of a high dose of methadone, which has a sedative effect in itself, plus other medications in excess that have sedative properties, namely the pregabalin and the clonazepam. So this client was daily dosing supervised by nursing staff at a drug health clinic.
So just also in the chat, Rowena, just to fill you in, Brian, as a psych reg, wants to know more about the context of the overdose. We've spoken about that, sorry. Kristen wants to know about the number of takeaways and concerns about patterns of use and diversion.
Yes, so there was definitely no takeaways. There wasn't any concerns about diversion. Someone had written about reducing the dose, counselling the patient about the risk in combining the medications, which we had done.
Yeah.
We had reduced it to 80 milligram daily. And we did discuss alternative OAT. As for the prescribers, there were, this patient had a history of aberrancy, doctor shopping, multiple prescribers on SafeScript. And on SafeScript, it was monthly scripts of, but it was up more than 4 prescribers of pregabalin within the span of 2 weeks. So there was 200 tablets of pregabalin that was prescribed within the span of 2 to 3 weeks.
So quite a lot of other prescribed drug use.
Yes. So we did contact the prescribers, and they, some of which didn't know about SafeScript. So we did provide the education about SafeScript.
And Dr. Nassim suggesting potentially slowly reduce him and send him for a detox.
Yes, that was an option that was done. Yes, the client was referred for a detox.
So was that, so what's the first thing you did? Because he was an inpatient when it happened.
Then it was all ED presentations. So the patient was admitted, but within 12 hours of admission had discharge against medical advice. And the time that we did the brief intervention was after the 3rd overdose, and it was in the outpatient setting because they came to clinic straight from emergency when they had discharge against medical advice.
Right.
Yes, he did have capacity. And in terms of contacting the prescribers, it was out of a duty of care, given these life-threatening overdoses that he had. Regarding the detox, it was a detox, a benzodiazepine detox. What also complicated this patient's history is that they did have a history of using alcohol. So alcohol used to sort of 4 litres of wine a day when they didn't have access to the prescribed benzodiazepines.
So essentially, are you able to keep a bit of an eye on the chat too, Rowena? Is that what you're doing?
Yes, I did.
Yeah, good. So essentially, everyone's suggesting sort of reduce or cease and go into a detox setting. Some other things that have come up include consider the ECG and cardiac risks of overdose with pregabalin.
Yeah, he didn't have a prolonged QT.
And basically, and also Nicole suggested lowering the dose, but also daily pickup. So no takeaways at all.
They were always daily pickup as a recent release from Justice Health.
Yeah. And Lee also suggests maybe a urine drug screen to check for
the money that the government grabs through land tax.
Sorry?
That sounded like the news, perhaps.
Oh, did it?
Yeah.
Oh, What's up with that? So Lee suggests maybe doing a urine drug screen to check for other illicit drug use. Did you do that?
Yes.
Do you recall whether there was?
It was mainly the benzodiazepines.
Yeah, so there wasn't any particular additional drugs that you didn't already know about. And would you do a sort of selective detox or detox all at once?
I think the first thing to address in this case was the benzodiazepines and the alcohol. They were on methadone in custody. I'm just referring to the chat.
Yeah.
One thing that was briefly brought up as well was SafeScript, and I guess this can really emphasize some people where SafeScript can come in handy as well. Would you agree, Rowena and Sharon? And it's something that prescribers should be very familiar with. A slight deviation was I quickly created a poll because it'll be very interesting to see. And the question is, have you used SafeScript in your clinical practice? Because, you know, there is discussions on whether or not people have actively used it or if you find that it's of benefit. If you've used it previously and you've got any thoughts on it, feel free to unmute yourself or include it in the chat. Good to see Brian using it every day.
Yeah.
I would assume with a lot of drug and alcohol patients, it would probably be quite regular. And I'll end that poll. We've had about 2/3 respond, but it looks like, yeah, nearly 90% of people who answered that quick poll are using SafeScript. So that is great to know.
Good. Okay, so shall we move on to the slides, Rowena?
Okay, yes.
Have you covered everything there, you think?
I think so, yes.
So this is the after poll now. So we're going to compare the before. So would you continue to prescribe methadone for this patient? What does everybody think?
And while everyone's responding, I just noticed Ivan just said that he can't access SafeScript from within ACT. So Ivan must be based in Canberra, which is very interesting. I might have send a quick email off to some of our colleagues at the SafeScript team, see if there's a workaround for that.
That is tough, given because I went to ANU in Canberra, and Queanbeyan, despite it being in New South Wales, they spend more time in the ACT.
I for a recent OTAC session that we did hold up on the North Coast, just for reference as well, there was someone who mentioned that they were able to access the Queensland version, but there was sort of a slight workaround that had to be sorted with the QScript team. So there might be a similar workaround with the New South Wales system, but I will make some inquiries because it'll be very interesting to know for our interstate colleagues.
There's Canberra script in ACT. It's been written in the discussion.
What was that? Sorry, Rowena?
There was a comment, Canberra script in ACT.
Oh, right. Canberra script in ACT.
Oh, he didn't have a driver's license, no. He was illiterate as well.
Right. So, and there are the poll results. So this is the second question about the, the before and after. This is the after. So how does that compare, Daniel?
I'll have to double check, but I'm pretty sure it was a bit higher for the first round. It was, let me just double check. Oh no, it was about the same. So 72 in the previous poll, 74 in this current poll %.
Yeah. So the summary is that people would be reasonably okay to continue to prescribe methadone, but to reduce the dose, ensure no takeaways, and detox from, or basically reduce and withdraw all the other medication. Someone's asking about camera script, any action on his driver's license if you have one? Do you know the answer to that one, Daniel?
Yeah, he didn't have a
Didn't
driver's
have one?
license.
In terms of their fitness to drive, though, assuming if they did have a license, what
No,
would you say
this-
regarding that, Rowena?
The fitness to drive,
Look,
that's
yeah.
definitely questionable, given the recent history of overdose, significant amount of sedatives on board.
Yeah, indeed.
Dan makes a good point in the chat about what if he doesn't want to do a detox?
Initially, he didn't, but the maintenance of engagement and the motivational interviewing is the important part, because he eventually did want to do a detox.
Yeah. But otherwise, you know, I mean, you were going to do it anyway. You're going to deprescribe. I mean,
Yes.
you weren't going to continue his medications.
No, not at the
reduced
current
doses.
dose with the overdoses and the amount of sedatives he had.
Yeah. Okay. All right. So shall we go to the next slide?
Okay.
Is that going? No? There it is. So this is the second part of the first case, the same person. So Mr. DN has agreed to an OAT medication transfer from methadone to depot. How would you approach transferring this gentleman from methadone to Buvidal? Select the most appropriate option for your setting or based on your experience. So A is cease methadone after 24 hours if opioid withdrawal is moderate to severe. For example, cows, commence transfer with buprenorphine sublingual. Start sublingual the next day with the same dose of methadone as part of the outpatient microdosing transfer to Buvidal. Reduce methadone to 80 milligrams and discuss with the patient about an inpatient switch to Buvidal. Reduce methadone to 80 milligrams and start an outpatient microdosing transfer to Buvidal, or something else.
Sharon, before we start the poll, so with option A, this cease methadone and after 24 hours opioid withdrawal is moderate to severe.
Yeah.
With the clinical opioid withdrawal scale, this is referring to what we call the standard of care transfer that has been done in the outpatient setting from methadone to sublingual buprenorphine, where according to the guidelines, if they've got a clinical opioid withdrawal scale score of above 12, 1 to 2 days after their last dose of methadone, and to suggest withdrawal, then they can start sublingual buprenorphine. That's what that option A is referring to.
Thanks, Rowena. So does everyone want to fill in the poll? So how's it looking, Daniel?
We've got about 55% responding. We'll give everyone a few more seconds because it's a long question or long responses. So we've got about 3/4 responding, so I might end the poll there just in the interest of time. And it looks like most people have put in option C in this case. A couple of people have said something else as well. So at some point, it'd be interesting to see what those people thought.
Yeah. So reduce methadone to 80 milligrams and discuss with the patient about an inpatient switch to Buvidal. Yep. And I think a lot of it does depend on obviously where you work and what the facilities are and what you can readily get access to.
And it may be you don't have Buvidal available. So I did notice Dan in the comments did say that he thought that methadone needed to be lower than 80 milligrams to make the switch. Did either of you want to comment on that? it looks like Rowena has in the chat already. So
What did you say, Rowena? Say it out loud.
So anecdotally, and this is from word of mouth, having spoken to the research nurse who had extensive experience on the microdosing trial, the best dose to microdose that they found from reviewing the clients so far has been at 100 milligram. And for standard of care transfer, the ideal dose was at 40 milligram, but it's still an ongoing process with clients taking up the option of microdosing.
And I think the other thing is, though, microdosing is still not part of the guidelines. So, and it's something done it was done at RPA in the context of a trial. So it's a little bit harder for others in different settings to engage with microdosing at this stage, depending on their experience. I know a lot of the people that are participating do have quite a bit of experience with microdosing, but it's still not formally part of the guidelines. Okay, so where do we go to now? Next slide.
So before the next slide, the intended answer I had for this question was C, to discuss an inpatient switch to Buvidal. It's high risk with microdosing, given that he already had the presentations of presenting to dosing intoxicated in the context of having had an overdose and then self-discharging from emergency. So with that polysedative use, and given that he was on a high dose of methadone, 130, and had only been on 80 milligram for a short time when we reduced the methadone to 80 milligram, and given that there is the risk of withdrawal, and when they are in withdrawal during this process of transitioning to Buvidal, if they're in the community, unless they're very motivated, someone like him would be vulnerable to resorting to sedatives to cope with the withdrawal. So hence, on discussing about Buvidal, we did discuss about an inpatient switch to Buvidal because that also facilitated the option for a detox as well from alcohol and benzodiazepines.
Great, thank you. So shall I progress the slide now?
Yes.
Thank you. All right, so this is still just a little bit more further discussion. Have you covered all these points, Rowena, do you think?
So with option D, again, a microdosing transfer, it would be risky because if he goes into withdrawal, he may resort to the sedatives. Starting the sublingual buprenorphine the next day with the same dose of methadone as part of, so that would, the implication of that was if you had him on 130 milligram methadone and then you start sublingual buprenorphine the next day, which is what microdosing typically is, you can start microdosing at the dose that they're already on, and that would have the same risk as option D. And A, to the standard of care transfer, it's not, we don't generally do a standard of care transfer if they're on a dose as high as 130 milligram, which is what he was originally on.
A quick question perhaps to consider is, what if inpatient was not an option at the end of the day? We're very privileged being in a hospital in inner city Sydney, but what happens if this case that wasn't an option at all? Any thoughts on that, Rowena or Sharon, or anyone in the audience from your own experiences?
Again, if inpatient may not have been an option if there was no hospital, if the hospital, they didn't have admitting rights for addiction medicine, for example, which does happen. Not every hospital has and inpatient admitting rights for drug and alcohol. There are hospitals that the teams can be admitted under general medicine, for instance, and then drug and alcohol can be consulted that way. So that's how an inpatient switch could still happen, even if it was not in an inner city setting. If a regional hospital, there are regional hospitals that have established general medicine services, for example. And the thing with the outpatient microdosing, you need experienced nursing staff that can do the clinical opioid withdrawal scale, that know how to do nurse-initiated treatment. For example, if there's a community medication chart at the clinic, and for example, there's PRN metoclopramide charted, then there would be the nurse that would be able to initiate those PRN medications based and titrate it to the symptoms, because in the outpatient setting for microdosing, people were being given clonidine and antiemetics. It's very interesting to hear that there has been success with using the microdosing even from doses as high as 200.
Okay, in the interest of time, we have to move on.
Okay, yes.
Did you want, there's a couple of slides coming up, Rowena, where you've got some information from the guidelines. Is there anything you want to reinforce before we move on to the next case?
This was from the New South Wales opioid treatment guidelines for 2018. And of note is of particular concern is use of alcohol, benzodiazepines, or other sedatives in conjunction with opioids because of an increased risk of overdose, particularly during methadone induction and during withdrawal attempts. So hence another reason why the referral for switching to Buvidal was done as an inpatient.
Okay. And this gives a little bit more detail about transferring the patient from methadone to Buvidal.
Yes, so the slide on the left, this is from the Buvidal guidelines, and the table on the right is from New South Wales opioid treatment guidelines 2018. So and this slide here is, for example, if a patient has demonstrated signs of withdrawal with a clinical opioid withdrawal scale of more than 12, these are the doses of the buprenorphine sublingual that can be started and the equivalent doses of weekly Buvidal.
Okay, so the after poll. How would you approach transferring Mr. DN, a high-risk patient, from methadone to Buvidal? Single choice. What does everybody think?
Got about 20% of people that have responded. When we hit 50%, I'll close it off, just in the interest of time, everyone.
Yeah.
Which we've hit. Looks like most people have said option C now, in this case. Wonderful. Any other questions regarding that case, or should we move on because it's already 20 to 7? So
yeah, we better keep moving. I'm just wondering, June Dye's written something in the chat about home visits. What do you mean, June? Like sort of visiting the patient in their home? Anyway, maybe if you could respond and we can keep pressing on. Okay. Okay, case scenario 2.
So this is a 40-year-old female with previous trauma and previous alprazolam dependence. She is currently prescribed diazepam 5 milligram 3 times a day with no aberrancy. She presents with an acute exacerbation of a chronic back pain since a heavy lifting injury 10 years ago, causing L5-S1 nerve root impingement and disc prolapse. After the injury, she became dependent on prescribed opioids, leading to the commencement of Buvidal 16 milligram weekly, which manages her opioid dependence and has improved her back pain and general well-being. Next slide. So this is before. How would you manage her current acute on chronic pain? Prescribe Penafiel and pregabalin is option A. Option B is prescribe oxycodone. Option C is to refer her to neurosurgery for surgical repair of a disc prolapse. Option D was to refer her to rheumatology outpatients for physiotherapy and an L5/S1 nerve root injection as an outpatient. And option E is something else.
Okay, we've got about 65% response rate at this stage. Again, in interest of time, I'll cut the poll a little short. Looks like most people have answered D in this case, Rowena and Sharon.
Yep. Okay, so we're just going to sit on that and then keep going with the presentation.
Okay, next slide.
Yeah.
So the way I thought about this case was we don't want to add to her risk of toxicity or overdose from sedatives by adding other medications with sedative properties such as pregabalin. Penafiel, she's already opioid dependent, and in the context of chronic pain and opioid dependence, they, in an inpatient setting when they're acutely in pain, they often require a larger amount of opioids than the standard patient that's not opioid dependent. And so that would factor in for option B. Option C, to refer to neurosurgery for surgical repair of a disc prolapse. There have been cases of people that have multiple back surgeries for things such as disc prolapse, only to be in even more pain. And she actually said that she was against surgery. So, and then option E, something else. Did anyone have any ideas? I guess something else could be non-steroidal anti-inflammatory medications.
Yeah, and I think there's some people are pointing out in the chat that a lot of the options are pretty difficult to achieve anyway, just in the real world, because getting her to see a neurosurgeon or a rheumatology outpatients, getting a nerve root injection, all costs money and resources, and it is difficult. But,
so I guess,
yeah,
yes, something else could have been simple analgesia and a referral to physiotherapy, but physiotherapy, even that in itself, it's not straightforward, because if people don't have, if there's a long wait list for outpatient physiotherapy, and say a lot of the clients I've come across can't afford insurance to be able to see a physiotherapist with insurance either.
Yeah. In the chat, some people are suggesting different options like simple analgesia, heat, physio, psychological support, reassurance, referral to a pain specialist, potentially injection with a local radiology service if it's relevant. And possibly antidepressants if they're also relevant to the particular person.
She was already on fluoxetine.
Okay.
No, but good ideas on the discussion. So there's a lot of options in something else.
Yeah. Okay, so do you want me to move on?
Yes.
Okay, so this slide just sort of summarises some of the key points that you made. Rowena, would you like to highlight?
Oh, this was from the New South Wales Opioid Treatment Guidelines 2018.
Mm-hmm.
So they said that there is a continuum of presentations between some people using pharmaceutical opioids rather than heroin for non-medical reasons, and others commencing opioid use for management of chronic pain and then progressing to opioid dependence. They did allude to tolerance, meaning that normal doses of opioids are less likely to be effective. And the need for a comprehensive treatment plan that addresses pain management. So interesting, a lot of people have mentioned duloxetine to address the neuropathic component of pain. And that also has antidepressant properties. So that would count as something else for option E. So we can go to the after poll now.
Mm-hmm. Give it a few more seconds. So put in your poll answers. And I think we'll end it there.
Okay.
Yeah, we all thought of something else.
Some really good discussion in the chat there. So
Yeah.
Thank you everyone for contributing to that.
In this case, for something else, the patient ended up doing the physiotherapy. They haven't actually gotten to having an outpatient nerve root injection. The referral was to radiology from the rheumatologist, but they did engage with physiotherapy, and the patient has started to see a psychiatrist as well as a psychologist as well. So I put this case as an example of someone who does have a history of benzodiazepine dependence and opioid dependence, but has demonstrated a willingness to engage in a multimodal model of pain management.
Great.
Sorry, this is Adam Mir. I'm a pain specialist and as a GP. So in this case, the last thing that we have on the option is actually multidisciplinary team care plan, because if you look at the other options, you can clearly see that, for example, rheumatologists just see the patient, wants the patient to have a nerve root injections, and neurosurgery, again, same as well. I think this patient definitely will have a benefit after the management of the substance use disorder. Definitely the patient will have a benefit from seeing the chronic pain team in the multidisciplinary manner. And physiotherapy, when we are talking about the physiotherapy, we have a lot of discussion about it, manual therapy, other type of the therapy, but really we need the physiotherapists that have some experience with the chronic pain, because this patient usually they have a central sensitizations, and that one is the big things for them. So that's the reason at least I choose other options.
Yeah. Thank you very much.
Thank you.
Move on, Rowena.
Yes.
Case scenario 3, we've got about 9 minutes.
So this is a 30-year-old man with a history of a schizoaffective disorder on olanzapine 10 milligram daily. He has a history of anxiety and benzodiazepine misuse in the context of anxiety. and takes 10 milligram diazepam daily. That's prescribed by a GP with no aberrancy. He's on methadone 100 milligram daily for opioid dependence, and he does have takeaways on weekends. He never presented to the pharmacy intoxicated for dosing. He's about to start university twice a week. He wants to start counselling and have more takeaways. Next slide. So what would you do about the takeaways? Would you stop the takeaways immediately because he's still on diazepam? Would you change his script so he can receive the takeaways during the week, go to university and start counselling? Reduce the takeaways because he's still taking diazepam? Reduce the methadone because he's taking diazepam or something else?
How's it looking, Daniel?
We've got about 65%, so I'll end the poll here, just in the interest of time again. Most have answered B in this case. We've got a few people that have said something else.
So how do you respond to that, Rowena?
Yes, so that I did agree with that because university was a main part of him being able to maintain his well-being. And when he initially started on the program and felt like he wasn't stable on the substance use, he actually had to take time off uni. So he felt it was important to be able to go back to university, to engage in classes and to have that social interaction again, and to give himself that motivation to come off substances, because he said he did want to come off diazepam eventually. So for him being able to function, to go to university was part of that. And he was very keen and motivated on engaging with counselling as well. Yes, university is a high-risk environment. Yes, it can be, but yeah,
I mean, I guess
in the context of his ways to improve his mood and non-pharmacological strategies as well, because I did stop his paroxetine due to the concern that there was a cytochrome P450 drug interaction with paroxetine being a cytochrome P450 inhibitor.
I think Wendy's also made a good point about the social interaction, which can be important for a client. And, you know,
I guess
them having a goal to go to university is something to consider as well. That's a positive step, potentially. Well, yeah.
The university high-risk environment's getting a bit of chat. Lots of pluses and potential minuses, but I guess as a clinician, you could try and follow him up a bit more often, make sure he's got plenty of other supports or strengths in place.
Yes, frequent follow-up, monthly follow-up has been important for the patient in terms of providing that therapeutic engagement.
Yeah.
And a chance for the motivational interviewing as well.
Yeah. And Brian's suggesting link with the uni health service too, potentially, which is not a bad idea if he doesn't have a GP that he's particularly engaged with on that's private and confidential enough for him. Good, thank you. Well, we've got 4 minutes left.
So next slide.
Mm-hmm.
This was from the New South Wales Opioid Treatment Guidelines 2018. It's a good rubrics and risk stratification for identifying clients, whether they have high treatment needs, moderate treatment needs, or low treatment needs. someone can have a benzodiazepine use disorder or benzodiazepine dependence. But if they show a motivation to come off the diazepam, for example, eventually, for example, I met a client today who said that they were having benzodiazepam non-prescribed, but they had a plan to taper their dose by 2.5 milligram once a week. And then once it was down to 5 milligram, then to reduce by 1 milligram per week by putting the tablet and splitting it into quarters. In that case, they may not necessarily be high treatment needs. And in the absence of significant psychiatric comorbidities, even if someone has psychiatric comorbidities, in this case, the schizoaffective disorder and anxiety and depression, if they've been stable with their medication and they're engaging with counselling, these clients could actually be, according to this rubric, under the moderate treatment needs. So the guidelines, they are open to interpretation, but they just provide a good framework.
That's good to highlight that. Thanks, Rowena.
Next slide.
After poll?
After poll.
Wonderful. And just while that's running as well, it always brings up a good point that we frequently bring up in the OTAC, which is if ever you think that there is, a clinically valid reason to go beyond what the guidelines say, that is okay. Make sure you notice and record that within your, relevant patient medical notes. If you're a little unsure, you can always discuss with another colleague or an addiction medicine specialist, or even DASIS. Of course, we have the phone number for DASIS at the end of the slide deck as well. So, yeah. And we've got about 60% participating again. So, and I can see it's nearly 7 o'clock. And we've got B again, 80% have responded.
So he gets to go to uni.
Gets to go to uni.
Good.
Wonderful.
Okay, next slide, Rowena.
Yes.
So do you want to wrap up, Rowena?
So these cases were 3 cases of polysedative use in the context of opioid dependence on opioid agonist treatment therapy. We did cover ways of discussing and proceeding with switching to opioid agonist treatment therapy, such as switching from methadone to buprenorphine for those with a history of polysedative use and a high risk. And as always, opioid agonist treatment prescribers need to consider patient preferences, be guided by the guidelines, so the rubrics that I showed in the previous slide, and considering patient preferences, such as in the last case, it was someone who was about to start university, understanding the risks, benefits, and processes involved in switching and initiating opioid agonist treatment, and knowing when to seek specialist advice is key.
Thank you. One final question. Alan's just said, who is monitoring this chap's QT?
We are at the clinic. So far on the ECGs, there's been no prolonged QT.
Very good point to bring up, Alan, though.
And does he have a GP? This guy, sorry.
Yes, because the patient had been prescribed diazepam with the GP. So,
okay.
Another point with the counselling. So the GP meant chronic healthcare plan with the referrals for the 5 subsidised sessions with a psychologist.
Good. Okay, great. All right. So 7:01. Sorry, we've kept you an extra 1 minute. Thank you everyone for coming along, and thank you very much.
Next couple of slides, Sharon, by the way, just to
what
wrap
am I
up.
going to do?
Next couple of slides, just to wrap up.
Sorry, yeah.
And thanks everyone for the discussion. There was a lot of good ideas in the chat. Thank you, everyone.
And there's just some contact numbers and things like that, which for things that we've mentioned within the session earlier. Also, just a quick reminder, just previous page, Sharon, sorry. We will not be running a webinar in April just because with Easter and I think it was Anzac Day from memory, it just sort of doesn't really work out, and we think everyone should have a 1 month off perhaps in that case. So our next scheduled webinar will be on 16th of May. We have a couple of upcoming topics as you can see as well, one around custodial settings and post-release, and we're hopefully going to have some representatives from Justice Health and private corrections attending. We've also got some topics on chronic pain management, mental health considerations, and there's a few other topics that we're sort of actively seeking for facilitators across the state. But as always, if you have a suggested case on any of these topics or a suggested topic, please feel free to email me. Other than that, thank you for joining us this evening.